1. CVS Caremark drops coverage of Zepbound. What you need to know. 2. Major insurance changes to GLP-1 drugs for weight loss. What you need to know. 3. How to get GLP-1 drugs covered by employer health insurance, 2025 update. 4. Wegovy and Zepbound price drops. Why access to obesity drugs remains tough. 1. CVS Caremark drops coverage of Zepbound. What you need to know. A major shift in healthcare coverage has sparked heated debates across the nation as CVS Caremark, one of the U.S.'s leading pharmacy benefit managers, PBMs, has decided to stop covering Eli Lilly's blockbuster weight loss medication, Zepbound. This move, attributed to the soaring costs of drugs like Zepbound, has ignited discussions about affordability, patient access, and the growing influence of financial incentives in medical decision-making. But here's where it gets controversial. While CVS claims this decision will save clients up to 15% annually on anti-obesity medications, critics argue it prioritizes corporate profits over patient well-being. What does this mean for the millions relying on these drugs to manage their health? Let's break it down. Zepbound, the brand name for Eli Lilly's tirzepatide, was approved by the FDA in 2023 for chronic weight management in adults with obesity or overweight individuals facing weight-related health risks. Originally developed to treat type 2 diabetes, tirzepatide has since become a cornerstone in the fight against obesity, with clinical trials showing patients losing up to 25% of their body weight, a feat surpassing even competitors like Novo Nordisk's Wegovy. However, CVS Caremark spokesperson Philip Lando told Fox Business that GLP-1 drugs like Zepbound are significantly contributing to overall plan costs, citing their egregiously high list prices as the primary barrier to access. This raises a critical question. Should patients be forced to choose between effective treatments and financial feasibility? CVS Caremark's decision is not without exceptions. If a patient's doctor deems Zepbound a medical necessity, coverage may still be available on a case-by-case basis. Yet, this nuance is overshadowed by broader concerns. As a PBM, CVS negotiates drug pricing between insurers, pharmacies, and manufacturers, acting as a gatekeeper in the prescription drug supply chain. Critics, including Eli Lilly, argue that PBMs need to rethink their role, as their profit-driven practices often inflate drug costs. Eli Lilly previously stated that reducing prices for U.S. consumers requires intermediaries like PBMs to take less for themselves, highlighting the tension between corporate interests and patient care. The fallout extends beyond cost-cutting. Dr. Christopher McGowan, a gastroenterologist and obesity medicine specialist, warned that CVS's decision is deeply disruptive for patients who have found stability on Zepbound. He emphasized that GLP-1 medications, while similar in name, are not interchangeable in practice. Switching mid-treatment, he explained, could undo hard-won progress, trigger weight regain, or introduce new side effects. For many, this isn't a simple substitution, it's a high-stakes gamble with their health, McGowan said. His concerns echo a larger issue. When financial agreements between PBMs and drug manufacturers begin to override clinical judgment, who truly benefits? Eli Lilly, unsurprisingly, pushed back against the decision, stating it is committed to ensuring patient access to necessary treatments. The company claims it has proactively communicated with affected patients and provided alternative pathways, including its self-pay program, Lilly Direct, which offers Zepbound at around $500 per dose. However, this solution is only viable for those who can afford it, leaving many without coverage in a precarious position. And this is the part most people miss. The decision to drop Zepbound isn't just about cost, it's about power dynamics in healthcare. When PBMs and manufacturers dictate which drugs are covered, who decides what's best for patients? As the debate rages on, one thing is clear. The intersection of medicine and money is no longer a quiet backroom negotiation. It's a public conversation that demands transparency, accountability, and a reevaluation of how we balance profit with patient welfare. What do you think about this decision? Should healthcare coverage prioritize cost savings over medical necessity? Share your thoughts in the comments below. 2. Major insurance changes to GLP-1 drugs for weight loss. What you need to know. Imagine being told that the medication you've been relying on to manage your weight, after years of trial and error, is no longer covered by your insurance. This is the harsh reality that many patients, like Tara Ecobaxi, are facing due to major changes in insurance coverage for GLP-1 drugs, a class of medications used for weight loss. Starting July 1, 2025, CVS Caremark, a prominent pharmacy benefit manager, will no longer cover Eli Lilly's Zepbound, a blockbuster GLP-1 drug approved by the U.S. Food and Drug Administration for chronic weight management in adults with obesity or who are overweight. But here's where it gets controversial. CVS Caremark will continue to cover Wegovy, a similar GLP-1 medication from Novo Nordisk, as well as a few other less effective medications. The decision is part of CVS Caremark's strategy to force drug manufacturers to compete with one another and drive down prices. However, this move has sparked outrage among patients and healthcare providers who argue that GLP-1 medications are not interchangeable and that volatile insurance coverage contradicts the science and experience of managing obesity as a chronic disease. As Dr. Tracy Zvenyak, Director of Policy Strategy and Alliances at the Obesity Action Coalition, puts it, largely across society, we don't accept obesity as a long-term chronic disease, and we're still looking for quick fixes and quick solutions where that's not the reality of the biology and disease process. The trial and error system of finding the right medication can be frustrating and time-consuming, and adapting to a change in medication can interrupt a patient's weight loss trajectory. Dr. Jody Dushay, an endocrinologist at Beth Israel Deaconess Medical Center, notes that as soon as these announcements come out, I get flooded with messages from patients who are stressed and anxious about the impact on their care. And this is the part most people miss, the human cost of these insurance changes. Patients like Ecobaxi, who have found success with Zepbound, may be able to file for an exception, but the process is often cumbersome and time-consuming. The sentiment behind these changes is also enraging, with many patients feeling that they are being judged and stigmatized for their weight. As Ecobaxi says, "You made me jump through hoops, and now you're taking it away from me mid-year." It's so impactful that it should be illegal. Although coverage exceptions may be an option, the appeals process can be frustrating and lengthy. In response to the coverage changes, Eli Lilly has expanded access to Zepbound through its Lilly Direct platform, which offers single-dose vials for $499 per month. But the question remains, what does the future hold for patients who rely on these medications? Will they be able to access the care they need, or will they be forced to navigate a complex and often unforgiving system? We want to hear from you. Do you think insurance companies should be able to dictate which medications are covered, or should patients have more control over their care? Share your thoughts in the comments below. 3. How to get GLP-1 drugs covered by employer health insurance, 2025 update. Unlocking access to GLP-1 medications, a call for change. The emergence of GLP-1 medications, which are designed to combat obesity and related cardiometabolic diseases, represents a significant advancement in medical treatment. However, a troubling reality persists. A vast majority of insured Americans find themselves unable to access coverage for these essential drugs. For many individuals, the only alternative has been to turn to compounded medications. Unfortunately, these drugs lack the safety assurances provided by the Food and Drug Administration, FDA, and their primary ingredients are often sourced from Chinese factories that do not adhere to the rigorous quality standards of FDA-approved products. This already subpar option is becoming increasingly unavailable, as the FDA has recently announced that brand-name GLP-1 medications are no longer in short supply, effectively banning the use of off-brand alternatives. In a recent statement, former President Trump highlighted the disparity in drug pricing, referring to GLP-1s as the fat shot. He shared an anecdote about a friend in London who revealed that the cost of these medications in the UK is approximately 1/10 of the price in the United States. While Americans face an average monthly cost exceeding $1,000, those in England pay around $150. Currently, there is no legislative mandate requiring pharmaceutical companies to lower their prices for prescription drugs in the U.S. However, there exists a straightforward pathway to make these medications more affordable for many Americans. Most health insurance coverage for employees is provided through employer-sponsored plans, which are funded by premiums from both employers and employees. Unfortunately, very few of these plans include coverage for weight loss treatments. If they were to do so, it would necessitate adjustments to the budget, likely resulting in increased premiums. The presence of toxic fat is a significant contributor to numerous cardiometabolic conditions, and GLP-1 medications have the potential to help individuals regain their health. Enhancing access and affordability to these drugs could have a transformative impact on public health, especially considering that approximately 88% of Americans are metabolically unhealthy. As awareness grows, employees are increasingly expressing their desire for access to these medications, and many employers are eager to provide plans that include coverage. Interestingly, brand name manufacturers offer a potential solution by providing their medications directly to patients for around $500 per month. However, there are hurdles. Individuals whose employer-sponsored health insurance would cover part of the cost of weight loss drugs are not eligible for this reduced price. Even at $500, the cost remains prohibitive for many. The lack of transparency in drug pricing in the United States complicates matters, as various entities take a share of the funds allocated by health plans. Streamlining the system for GLP-1 medications could enhance accessibility. Presently, a drug purchased from the manufacturer at $1,000 may include a $300 rebate negotiated by a pharmacy benefit manager and a $150 discount coupon from the manufacturer. This convoluted pricing structure results in a final cost similar to the $500 price offered directly to patients without coverage. By eliminating rebates and coupons, manufacturers could charge employer-sponsored health plans the same $500 price they offer consumers directly. If employers were to contribute a portion of the cost, for instance, $300 per month, the out-of-pocket expenses for employees could align more closely with the prices seen in other countries. This would create a straightforward, rebate-free, and coupon-free system with reasonable cost-sharing from employers. The existing rebate system was originally designed to incentivize certain manufacturers to persuade pharmacy benefit managers and employer-sponsored health plans to favor their products. However, in the case of GLP-1s, where only two primary drugs are available and both have publicly accessible clinical trial data, such incentives are unnecessary. Recent agreements between pharmacy benefit managers and drug manufacturers have often prioritized financial interests over clinical appropriateness, leading to drug preferences based on corporate benefits rather than patient needs. Making these medications affordable would significantly alleviate one of the most frustrating aspects of the healthcare system, the requirement for prior authorization. Doctors' offices are often forced to expend resources navigating barriers that limit the use of healthcare dollars for expensive medications, even when physicians believe their patients genuinely need them. While GLP-1s are effective for many, they also carry certain risks. It is crucial that we allow healthcare providers to engage in shared decision-making with their patients regarding whether the benefits outweigh the potential risks. To further incentivize pharmaceutical companies to lower their prices and encourage employers to share in the costs of these medications, the Trump administration should consider reinstating coverage for GLP-1s under Medicare, as the Biden administration previously proposed. This year, Trump reversed that initiative, preventing Medicare and Medicaid from utilizing these drugs to treat obesity. While this plan to simplify payment structures and broaden access may not make all medications affordable in the United States, increasing accessibility to GLP-1s could pave the way toward addressing the pressing issue of cardiometabolic disease and enhancing public health. David A. Kessler, a former commissioner of the FDA, is the author of Diet, Drugs, and Dopamine: The New Science of Achieving a Healthy Weight. What are your thoughts? Do you believe that simplifying access to GLP-1 medications could truly transform public health? Or do you think the current system has its merits? Share your opinions in the comments. 4. Wegovy and Zepbound price drops. Why access to obesity drugs remains tough. A dramatic drop in the price of blockbuster weight loss medications like Wegovy and Zepbound is making headlines, but don't celebrate just yet. Consistent, affordable access to these drugs remains elusive for many who need them most. Wegovy and Zepbound, which have quickly become household names in the fight against obesity, still come with a whopping monthly price tag around $500 for those without insurance. That's a financial barrier that keeps them well out of reach for countless people. Even those lucky enough to have insurance can find that what's covered and how much varies wildly, leaving patients and doctors grappling with uncertainty. Matt Majewski, a Duke University professor and expert in obesity treatment coverage, sums it up perfectly. The medications should be available, but at what cost, and can people actually afford to keep taking them? This isn't just a numbers game. It's a matter of access and sustainability. The demand for these new GLP-1 receptor agonist drugs is skyrocketing. Zepbound, for example, pulled in an eye-popping $2.3 billion in U.S. sales in just the first quarter of this year, making it a top seller for Eli Lilly. Meanwhile, Novo Nordisk's Wegovy racks up about 200,000 prescriptions every week in the U.S., totaling nearly $1.9 billion in sales over the same period. But here's where it gets controversial. Even with these staggering profits and growing demand, the health insurance landscape is a patchwork of inconsistent coverage. Mercer, a major benefits consultant, reports that more large employers are starting to offer coverage for these injectable drugs to their workers and families, a promising trend. Novo claims that 85% of its insured U.S. patients pay $25 or less each month if they have coverage. Patients with diabetes may have an easier time accessing similar drugs like Ozempic and Mounjaro from Novo and Lilly, respectively, which are also GLP-1 drugs but specifically approved to treat diabetes. And this is the part most people miss. Most Medicaid programs and Medicare, federal insurance for the elderly, refuse to cover these medications for obesity at all. Even private insurance plans that do cover them often only pay a portion of the cost, leaving patients to shoulder hundreds of dollars in monthly out-of-pocket expenses. Drug makers sometimes step in with financial assistance, but those programs are often limited in scope and duration. Having coverage doesn't always mean you can get the drug, says Dr. Beverly Chang, a New York physician and paid advisor to both drug makers. She points out that patients often get stuck with unaffordable copays even when their insurance technically covers these drugs. Why the hesitation from insurance companies and employers? The sheer number of people who could benefit and the possibility that patients may need medication indefinitely have many bill payers worried. Some big employers have actually dropped these drugs from their coverage due to cost concerns. Pharmacy benefit managers, PBMs, the powerful middlemen in the drug pricing world, are also making strategic choices, sometimes picking one brand over the other to secure better deals. Consider this. CVS Health, which runs one of the largest PBMs in the country, decided to remove Zepbound from its list of covered drugs nationwide as of July 1st, opting to favor Wegovy instead. That move forced Dr. Chang and others to scramble for alternative treatments for patients who specifically tolerated Zepbound better due to fewer side effects like nausea. Dr. Courtney Younglove, based in Overland Park, Kansas, has to manage expectations up front. Her office sends prospective patients a video explaining how to check for insurance coverage before booking an appointment. Sadly, many cancel their visits when they discover they can't afford the medication anyway. There's another layer to this complex story. For a time, compounding pharmacies could legally make cheaper, off-brand versions of Wegovy and Zepbound during drug shortages. However, the FDA recently ruled those shortages are over, generally ending the practice, unless the medicine is custom compounded for individual patients, a narrow exception. Telehealth companies like Hims and Hers Health are still pushing the boundaries by offering bespoke doses of semaglutide, the active ingredient in Wegovy, that can be tailored to manage side effects. Hims claims their plans start at $165 a month if paid up front for a year. But this practice is controversial. Eli Lilly has taken legal action against compounding pharmacies and online health platforms, arguing these copycat versions pose safety risks because their ingredients often come from overseas suppliers not closely monitored by U.S. regulators. Hims counters that it rigorously verifies its ingredients, using third-party labs to ensure safety and correct dosing. Still, the debate rages on. Novo Nordisk even ended a short-lived collaboration with Hims over this very issue, citing patient safety concerns. And here's a jaw-dropping fact. Even with recently reduced sticker prices, $500 a month eats up about 14% of the average American's yearly income, which is roughly $43,000. For context, that's a massive slice of many families' budgets, often more than what people spend on groceries or utilities. There's hope on the horizon for lower prices. Both companies are working on pill versions of these treatments, expected to launch in the next year or so. If successful, pills could finally introduce real competition and drive down the cost of injectable forms. Some patients are already finding ways to cut costs by sourcing their medication from Canadian pharmacies, saving up to 15%. Dr. Younglove notes that international competition, along with the arrival of pill versions, could kick off a price war in the U.S. "I think we're just at the beginning. There's reason to be optimistic," she says. Controversy alert. Should the U.S. government and insurers do more to make breakthrough weight loss drugs affordable for everyone? Or are the current high prices justified by the costs of research and development? Have you or someone you know struggled with insurance denials or sky-high out-of-pocket costs for these medications? Add your voice to the debate. Do you think price competition and innovation will solve the problem, or is systemic reform needed? Share your thoughts below. Associated Press Health and Science Department receives backing from the Howard Hughes Medical Institute's Science and Educational Media Group, but retains editorial independence.